Hello, and thank you all for listening to this presentation on our research on histotripsy for the non-invasive treatment of biofilms in catheter-based medical devices. Starting off with a little bit of background, biofilm formation in medical catheters is a major source of hospital-acquired infections. What's happening here is we're having bacteria that are introduced from the outside environment into the catheter lumen. Once they enter the lumen, these free-floating planktonic bacteria tend to migrate towards the wall of the catheter. Once on the wall of the catheter, they will grow and replicate and ultimately begin to secrete a polysaccharide matrix, which we call biofilm. This biofilm will confer a resistance of the bacteria to flushing and antibiotic treatment and other modes of removal. Recently, however, histotripsy has been developed as an effective method for ablating biofilms from medical catheters. Histotripsy is a non-invasive, focused ultrasound therapy that our lab has recently found to be highly effective for this purpose. Current methods, however, do not provide treatment in a clinically relevant time frame. Using the best methods established in Childers et al. In 2021 would require about 8 minutes of treatment per centimeter of catheter. This would correlate to almost 6 hours for the treatment of a standard length urinary catheter, meaning this is not currently a clinically applicable treatment modality. The purpose of the present study was to develop new methods to improve the speed and efficacy of biofilm removal using histotripsy. In this study, we used a Pseudomonas aeruginosa-based biofilm, which was cultured in the lumens of medical catheters, as you can see in Figure C and Figure D. Once this was done, a 16-element 1 megahertz transducer was used to apply focused ultrasound to the lumen. This focused ultrasound beam was then applied along the length of the catheter by using a 3D positioning system to move the catheter through the transducer focal point, as depicted in Figure A. Once this was complete, remaining biofilm after treatment was then quantified using spectrophotometry. In this study, we had 3 major areas that we wanted to optimize histotripsy treatment of biofilms. First of all, we wanted to determine the minimum effective dose for biofilm removal. As I mentioned previously, prior studies have established this as an effective method for removing biofilm, but have not yet quantified the minimum effective dose to achieve this. Next, we wanted to optimize the histotripsy scanning methods and dose. So prior studies had used a point-based application method of histotripsy, where the transducer would apply a given number of histotripsy pulses to a set point on the catheter, then move a distance down and apply histotripsy at the next point, and then move down and apply histotripsy at the next point, and so on and so forth. In our study, we looked to move towards a continuous application of histotripsy in one motion along the length of the catheter to provide a more even dosage. Next, we wanted to look at increasing the pulse repetition frequency of histotripsy. This would functionally allow us to apply more histotripsy pulses per second along the length of the catheter, thereby improving application speeds. So the results of our initial studies on minimum effective dose can be seen on this graph here. On the left side, we began by looking at pulses per point. So we started off using the methods developed in Childers et al., starting with 500 pulses per point using this point-based application system. We steadily decreased this down to 100 pulses per point with no loss in biofilm removal efficacy. Our next experiment, we looked at increasing the step length to see if there was any reduction in biofilm removal efficacy. And once again, by increasing from the step size seen in Childers et al. All the way out to 2 millimeters, we saw no reduction in efficacy. So even at these substantially reduced doses, histotripsy is still effective at removing biofilm. Our next experiment looked at moving to continuous scanning. This was done to both increase the efficiency at which histotripsy was applied, as well as to further try to quantify the minimum required dose to remove biofilm. So as you can see on the graph on the right, we started off with a 60-second scan along the length of a 2.5 centimeter catheter. We gradually decreased the scan time all the way down to 5 seconds across the 2.5 centimeter catheter. We can see that there was almost complete biofilm removal all the way down to a 20-second scan time. Once we reached a 10-second scan time, however, there was a significant reduction in efficacy of treatment, and then a further reduction with a 5-second scan time. Our next series of experiments looked at trying to restore the efficacy of biofilm removal even at these faster speeds by increasing the pulse repetition frequency at which histotripsy is applied. On the graph on our far left here, we can see that we used the 10-second and the 5-second scan times from our previous study, as well as a 2.5-second scan time to see if we could achieve a biofilm removal effect even at faster speeds than previously studied. As we saw in the last series of experiments, at the 10 and the 5-second time point, we saw a reduction in the efficacy of biofilm removal. And once again, we can see that at 2.5 seconds when applied at 200 hertz. When we increase, however, to 500 hertz, we see a almost complete restoration of biofilm removal efficacy. Once we increase to 750 hertz, we see further improvements with a reduction in standard deviation observed here, signaling more consistent results. At 1000 hertz, we saw a mild increase in our standard deviation at the 5 and the 2.5-second time points, but we still saw near complete biofilm removal. Once we had determined the optimal methods to ablate biofilm using histotripsy, our next series of experiments was to determine if these new parameters could be used to improve the time required to induce a bactericidal effect using histotripsy. In the figure on the left, we can see that histotripsy bubble clouds occur throughout the catheter lumen, allowing for the killing of planktonic bacteria. In the graph on the right, we can see that a significant reduction in viable bacteria was observed starting at 2 minutes of treatment along the 2.5 centimeter catheter, with over a 4-log reduction in viable bacteria being observed with 6 minutes of treatment. So, from this study, we can conclude that biofilm ablation in medical catheters is achievable at approximately 500 times faster than our prior study. These optimized treatment parameters would allow for effective biofilm removal from commercially available catheters in under 1 minute. While these are very impressive results, additional work is needed to develop these technologies to allow for the in situ treatment of full-length medical catheters. And here is our acknowledgement slide. Thank you so much for listening to our presentation today.